Now I request Dr. PRABHU Shankar, Vitreoretina, Head of Department Vitreoretina, Shankar Eye Hospital, Coimbatore, to talk about anti-VEGFs during cataract surgery.
Thanks, Rini, for the invite. So use of anti-VEGF in cataract surgery. So choice and timing. There's always confusion. We have a hard cataract. Fundus shows there some hard exudates in the macula, whether it's a DME or not. Your patient has old BRVO, and patient also have a CNVM. So we're not sure. So indications for anti-VEGF injection in cataract surgery is usually we combine it in patients with CNVM, macular edema, two scenario. Either patient could have a diabetic macular edema or a vein occlusion. In some cases where the cataract is very hard, fundus is not seen, and B scan shows some evidence of vitreous hemorrhage, but no RD. That's a condition where you can always combine cataract surgery with an anti-VEGF injection. So the concern with performing cataract surgery in patients with diabetic and macular edema is the potential risk of transient worsening of edema after surgery. This is because there's increased inflammation and breakdown of blood-retinal barrier post-cataract surgery, and it's been noted that the VEGF following cataract surgery is peaks in the first 1 day, or tenfold, and by around 1 month it tapers down. So there's an increased activity of VEGF for the first 1 month of cataract surgery. Probably that's a place where we need to use the steroids also. And angiogenic inflammatory mediators play a role in cataract surgery, may increase the vascular permeability, and which match, patient already predisposed to macular edema, it can worsen the macular edema. So common scenario for referral for retina specialists in diabetic patient is rule out DME. So you see a few hard exudates, and the cataract surgeon is really confused whether to go ahead with the steroid injection during cataract surgery or anti-VEGF, or do cataract surgery and later do the injections. So one of the indicators for, a few of the indicators for visual prognosis following cataract surgery in diabetic patients is whether the macular perfusion status, whether there's a pre-evidence, there's the presence of macular edema, and the stage of diabetic retinopathy. So according to the DRCA network protocol Q, the incidence of developing macular edema post-cataract surgery in patients without preoperative diabetic macular edema is very low. However, presence of a non-central DME immediately prior to cataract surgery or history of DME treatment, be it laser or in previous intra-intervention, may significantly increase the chance of developing a post-macular edema following cataract surgery. So it's an interesting meta-analysis showing anti-VEGF injections in cataract surgery. So they've compared non-peripheral retinopathy, NPDR, without DME and with DME. So they've compared two injections. One is bevacizumab, that is Avastin, and the ranibizumab, that is Accentrix. So what they found out is the Avastin effect is usually around 1 month, but when they use ranibizumab, that effect is always close to 6 months. So in this study, they said the mean number of injections was higher in the Avastin group, that is the bevacizumab group, than the ranibizumab group. So timing, when to give the injections in a patient, when diagnose that patient has a DME, they divided this group in 3 groups. The first group received ranibizumab 2 weeks prior to surgery. The second group received ranibizumab intraoperatively, and third group received 2 weeks postoperatively. There's one article where they measured the VEGF level, and they found that it's the peak effect of VEGF is around tenfold in the first postoperative day, and slowly tapers around 1 month. So the best ideal time is, so intraoperative injection of anti-VEGF was found to be more effective than pre or post injection for diabetic macular edema. So the word of steroids, IVTA is best combined, as intravitreal triamcinolone is best combined during a cataract surgery because the risk of cataract formation and IOP is less when we compare when you do together than giving it preoperatively then performing the surgery. One interesting study on DexCat study, that is intravitreal dexamethasone implant given 1 month before and combined are used during the cataract surgery. So what they demonstrated is whether you give it 1 month before or during cataract surgery, the effect almost same. The only advantage is usually the macular edema is likely to start around 4 weeks, then peaks around 12 weeks, then fades off. So the best time to give a DEXA implant is combined approach, that is giving a DEXA implant during cataract surgery than giving it prior to a cataract surgery. So patients with pre-existing PDR, so you know a patient has little vitreous hemorrhage, some tractional bands. So ideal is if you're able to do a minimal PRP, you can do it. The lens opacity precludes the period of PRP. So you can always combine an anti-VEGF during cataract surgery. And following the cataract surgery, you can always do your PRP, whether it be it by indirect or using 90D, you can do a PRP following cataract surgery. To eye with neovascular glaucoma, or you will see a lot of rubeosis, patient has a dense cataract. So it's always better to inject the anti-VEGF agent so that there's NVA negation, and phacospectin can be considered post-injection, because the incidence of postoperative hyphema and raised IOP is less when you give the anti-VEGF prior to the cataract surgery. The interesting article is a Monk et al. Method. In case you've done a cataract surgery and there's edema around 4 weeks, so how to differentiate whether patient has developed the edema only because of the cataract surgery or patient had some amount of pre-existing diabetic macular edema. So this OCT shows that sometimes both OCTs look similar. The only catch is we have to look at the outer 3 retinal bands. There's always a disruption of the photoreceptor layer and diabetic macular edema, whereas in the pseudophakic cystoid macular edema, the photoreceptor layer is intact. So this gives a clue that probably is more of pseudophakic cystoid macular edema than a diabetic macular edema. So phaco in patients with CNVM, there's always a concern about cataract surgery being performed in patients with AMD. There's a perceived exacerbation of leakage and submacular hemorrhage, and a predisposition towards other non-macular complications such as retinal detachment and increased intraocular inflammation. So there are 2 reports. Report 5 on ARS2 study showed that cataract surgery improved overall mean visual acuity in patients with different grades of severity of the AMD. And Rosenwein et al. Showed that there's been patients in the study, in the trial, who received cataract surgery while on treatment with ranibizumab had an increased visual acuity gain of more than 10 ETDRs line. So there's another article saying that's showing that the safety and effectiveness of cataract surgery and simultaneous whether give anti-VEGF along with exudate ARMD. In this article, they concluded that the visual acuity does improve even if patient has an exudative AMD. So timing, they have compared a lot of timing, like whether to give it during cataract surgery or 2 weeks post-cataract surgery, but the results are almost the same. But they've said that it's ideal to always combine it with the cataract surgery so the patient avoids 2 procedures. So patients with recently stabilized choroidal neovascularized membrane received an injection of ranibizumab, bevacizumab 1 to 2 weeks before cataract surgery. The advantage of this is giving a prophylactic preoperative anti-VEGF stabilizes the potential subclinical choroidal neovascular activity and minimizes the risk of hemorrhage and edema post-cataract surgery. So combined procedure doesn't seem to aggravate the choroidal neovascular exudation, and there's always a mean BCVA. There's more of 10 letters gain compared to a 2 letters gain. So it's always not necessary to maintain a dry retina. So sometimes in chronic CNVM, there's always some amount of fluid there. But when you feel that patient has received adequate injections, you can always go ahead with the cataract surgery, but always better to give 1 injection during a procedure. So in patients with vein occlusions, combined therapeutic approach did not cause a worsening of macular edema in patients with BRVO or also CRVO. There's always a improvement in visual acuity. So patients with cataract who are actively managed for macular edema due to RVO and anti-VEGFs, they can undergo a cataract surgery. Definitely there will be a transient increase in macular edema post-cataract surgery, but resolves without adjusting the frequency. That is in patients who are receiving monthly injections or twice monthly injections for routine vein occlusions. So you don't need to adjust the dose. In case you have planned to do a cataract surgery, you can go ahead with the cataract surgery, but patient will receive a regular routine dose of the anti-VEGF and doesn't affect the vision of the patient. So only caution is we do use a lot of anti-VEGFs like be it bevacizumab, ranibizumab, and efablessib. And the new drug is the brolucizumab. The only concern is that is a lot of foreign literature has reported that a lot of intraocular inflammation and retinal vasculitis. But Indian literature till date has not shown so much of results as the Western literature, but always better not to combine this drug when you're doing a routine cataract surgery, because post-cataract surgery, if patient develops reacts inflammatory intraocular inflammation, you really don't know whether it's the drug which is causing the inflammation or with the cataract which has caused the inflammation. So better avoid the drug during a cataract surgery. So choices, there are several drugs to whether in case you take a DME, there are several drugs. The only thing advantage of using bevacizumab is it's a lower cost, the efficacy also is good, and also the results are always comparable to your Accentrix or ranibizumab. So advantages of combined therapy is there's a better fundamental visualization for further management of the retinal procedures, no additional procedure, the visual results are always better, and higher patient satisfaction rate. Thank you.